I'd like to welcome you all to the, on behalf of the John Conley Division for Medical Ethics and Humanities, to our third annual symposium on the bioethics of healthcare administration. Thank you all for coming. Thank you all for registering and then for coming. Without further ado, I'm going to turn over our mic for some opening remarks to Dean Chuck Brunicardi. Thank you.
Thank you, Dr. Rose. Well, good morning, everyone. Welcome. We're so glad that you could join us today for our third annual Bioethics Symposium, the Bioethics of Healthcare Administration, which is being sponsored by the John Conley Division of Medical Ethics and Humanities at Downstate. We extend our special thanks to the John Conley Foundation for Ethics and Philosophy in Medicine for their generous support of our Division of Medical Ethics and Humanities, which they have supported since their first gift in 2002. Dr. John Conley was a pioneer in treating head and neck cancers and a close friend of our former chair of otolaryngology, Dr. Frank Lucenti. Through their lifelong friendship, Dr. Lucenti and Dr. Conley, along with Dr. Monica Conley and others here at Downstate, established the John Conley Division of Medical Ethics and Humanities. Today, we honor their passion for the field of medical ethics. Downstate's partnership with the Conley family is a key reason our medical ethics program remains strong. Thanks to their support, we continue to conduct critically important work through the John Conley Division of Medical Ethics and Humanities. In today's challenging times, rapidly evolving policies are reshaping the landscape of healthcare administration. It is difficult to keep up with these changes. Our patients face rising costs, limited resources for safety net hospitals, and growing health disparities. As providers, we face tough decisions with a determination and commitment to provide high-quality care in this community. Today's symposium will address these significant issues. Today's event is the collaborative effort between the College of Medicine, the College of Nursing, and the University Hospital at Downstate. I want to express my gratitude for the exceptional relationships within the individual colleges of SUNY Downstate Health Sciences University, which is a testament to our institution's leaderships, including the deans of their respective schools. I would also like to thank the organizers of today's symposium, Dr. Jason Lazar, Dr. Michael Rose, Dr. Rami Nakashbandi, Dr. Marie Claire Roberts, and Ms. Taryn Toval-Turpin. I look forward to hearing today's presentations. Our keynote speaker is Dr. Adam Gaffney, an assistant professor in medicine at Harvard Medical School, where he practices pulmonary and critical care medicine. He's a member of the Cambridge Health Justice Lab, focusing his research on healthcare financing, reform, equity, and lung health disparities. We will also hear from patients about their perspectives on access to care. Now, following this, a distinguished panel of interprofessional leaders will share their insights. We will conclude with our plenary speaker, Dr. Howard Minkoff, the Chair Emeritus of Obstetrics and Gynecology, Professor of Health Policy and Management in the School of Public Health, and a nationally recognized leader in maternal and fetal medicine. So thank you, and I look forward to an enlightening day ahead. Thank you.
Thank you very much for the warm introduction, Dr. Brunicardi. I will keep things going with one more set of introductory remarks from our Dean from the College of Medicine, Dr. Jason Lazar, who will be saying a few words.
Okay, good afternoon, everyone. I'm delighted. I'm actually pinch hitting. This brief introduction to all of healthcare administration and its role in healthcare delivery was envisioned by somebody else, but there was a conflict, and I'm asked to pinch hit, and I'm delighted to do so. So, good afternoon and welcome, and I'm delighted to provide some introductory remarks for the third annual John Conley Annual Symposium. Today we embark on a thought-provoking journey into the realm of bioethics and healthcare administration, a topic that not only shapes decisions made in hospitals and clinics, but also defines the moral compass of our healthcare systems. Since the discipline of bioethics was first popularized in 1971 as, quote, the combination of bioscience with humanistic knowledge, bioethics at its core is the study of ethical dilemmas arising from advances in medicine, biotechnology, and healthcare delivery. The questions of what is the right thing to do and what are our obligations to one another? These questions resonate deeply with both healthcare providers and administrators, albeit in distinct ways. However, the application has become much broader today. It includes clinical decision-making, implications of emerging technologies, global concerns, and of course, public policy. In fact, bioethics has played a central role in influencing policy changes and legislation in recent years. Its relevance for medical professionals is difficult to overstate as the modern healthcare system continues to evolve at a mind-boggling rate. Before we go any further, I'd like to thank the Planning Committee. Dean Brunicardi already mentioned all of their names. I'd like to also acknowledge Ms. Vanasco for helping to take care of some of the logistics today. And I'd like to acknowledge our Chief Financial Officer, Dr. Richard Miller, who in many ways catalyzed this today's symposium. So as compared to administrators, providers adhere to ethics to support improved patient outcomes and better overall health and well-being. And whereas administrators focus on organizational ethics, considering collectives such as groups of clinicians, patients, non-clinical workers, and institutions. Healthcare providers, therefore, face bioethical challenges on a systemic level. Their decisions affect not just individual patients, but entire organizations and communities. Administrators must balance competing priorities, financial sustainability, equitable access to care, and compliance with regulations. For instance, they may need to decide how to allocate various resources during a crisis, hence the pandemic, or whether to invest in expensive medical technologies that could strain budgets but improve the outcomes for some patients. Providers adhere to core ethical principles, and they are beneficence, actions to promote good, non-maleficence, avoiding doing harm, autonomy, freedom of choice, and justice, where we seek fairness and equal treatment. However, administrators have other obligations. As I alluded to before, patients, communities, the organization, and the organization's staff. Therefore, the ethics of healthcare administration is a bit more complex, and given diverse levels and different types of the healthcare administration, I even see the issues on the medical education side. Let's start with the patients. The ethics of healthcare administration has been termed a hybrid of business ethics and biomedical ethics. The interest of the patient is actually the prime duty of the healthcare administrator, and the American College of Health Executives calls healthcare administrators chief patient advocates, and basically states that they have an independent duty and responsibility to the patient above and beyond that of providers. With regard to the community, again, there is a code of ethics put forth by the American College of Healthcare Executives, and there are 5 general moral obligations. 1, working to identify and meet the healthcare needs of the community, supporting access to healthcare services for all persons, encouraging and participating in public dialogue on various issues related to healthcare, applying short and long-term assessments to make management decisions that may affect the health of the community, and number 5, providing prospective patients with adequate and accurate information. With regard to the organization, there is a fiduciary responsibility of the healthcare administrator. There are issues of confidentiality, conflicts of interest. Healthcare administrators are, quote, ethically accountable for the effects of nonfeasance, misfeasance, and malfeasance affecting patients, staff, and organizations. And they are basically wrongdoings, either by intent or simply by honest mistake. Healthcare administrators must balance a number of internal and external goals and standards, including values and standards of their community, local, state, and federal regulations. The staff. Healthcare administrators have a duty of loyalty and a fiduciary role to the staff. They also have various staff well-being issues. Therefore, in balancing resources, their healthcare administrators face veracity, the obligations to tell the truth, confidentiality, privileged information, and fidelity, keeping their promises. All of this with the difficult mission of balancing resources. To understand the challenges of healthcare administrators, let's start with an overview of how the healthcare systems are structured in terms of private and public elements. Conceptually, you could think of a healthcare system in 2 main dimensions. 1, insurance, and 2, delivery. Insurance refers to whether a private entity or it's the government that administers the actual plan and the premises by which patients are taken care of. It's whether people have private or public insurance. Delivery refers to whether the providers of healthcare are in the private or public sectors. In other words, are doctors working for themselves or for others, or do they work for government or hospitals that are either privately or publicly owned? When derivations exist, there are 3 major models of, although derivations exist, there are 3 major models of healthcare systems. In the US, we have a mixed model, which is largely entrepreneurial, mostly private in terms of insurance as well as delivery. This is in contrast to the United Kingdom and Germany, where healthcare systems are mostly public, but based upon other mixed models as well. What drives these differences in healthcare systems? It's basically values. In the Europeans, they value public good and social solidarity, whereas the American system values individualistic ethics, individual good, but this leads to social fragmentation. Therefore, different values underlie each system. And these different systems can be analyzed with regard to 3 categories of analysis: organization, insurance pools, public-private mix, quality, choice, and access, and, of course, the problems that they pose. This is a simple diagram showing the flow of funds in the United States healthcare. And they result from the values in the healthcare system posing a complex set of finances. Ultimately, the funds flow start with private households, which by taxes to state and federal government or paying for private insurance gets distributed to healthcare providers, both individual and institutions. Public and private hospitals receive payment from both public and private financing sources, and hospitals are typically paid through DRGs, diagnostic-related groups set by Centers for Medicare and Medicaid, the so-called CMS. CMS assigns a set payment amount for a particular condition or codes that are used by the hospital system for billing and reimbursement. They, alternatively, the physician's fees are not included within DRGs. Outpatient codes are very different, and they represent a fee-for-service style of billing rather than the capitated cost-based style of DRGs. So These APC codes, outpatient codes, are governed by what's called CPT, current procedural terminology, which is billed under the name of the provider rather than the actual hospital. And this may be used for either inpatient or outpatient services. So private insurers pay for hospitals based on DRGs, case rates, per diems, fee-for-service, and discounted fee-for-services. Conversely, hospitals on average are reimbursed less than the cost of services for Medicare, Medicaid, and for uninsured patients. Accordingly, all components of the healthcare system need to be managed and their processes administered by who else? Healthcare administrators. And they have a series of a whole host of problems to deal with, especially in the United States. A large segment of the population is uninsured. Our World Health Organization ranking for health attainment isn't great. The percent of the gross domestic product spent on healthcare has now reached over 24%, as health care costs have skyrocketed, and there are significant health disparities by race and by income. Moreover, we are the only industrialized country in the world without universal health coverage. The bottom line is that spending is high, and some aspects of quality are low, and the healthcare administrator needs to deal with these issues at all particular levels. Here are some real-world examples of dilemmas in healthcare administrators face: allocation of limited medical resources, withdrawing life support, implementing mandatory vaccination policies for patients or staff, whether they want it or not, balancing financial constraints with the quality of patient care and incentives for harder work, and a big one is patient confidentiality versus broader public health needs or organizational transparency. These examples highlight the critical role bioethics plays in guiding healthcare administrators as they make decisions that impact individuals, organizations, and the community. What's the old line? I'm not really a doctor, but I play one on TV. Well, there's some administrators that are not really administrators, but they play one on TV as well. While typically not the central focus of medical dramas, healthcare administrators are often depicted in dramatic and glamorous manner, just like physicians. There's Dr. Lisa Cuddy from House MD, who serves as the Dean of Medicine, and she clashes with Dr. Gregory House, often finding herself in conflict with him while managing hospital operations and overseeing medical staff. In the show, New Amsterdam, Dr. Max Goodwin serves as the medical director of a public hospital, focusing on the administrative challenges in reforming their healthcare system. And in the show Royal Pains, Evan Lawson, the chief financial officer of Hank Med, looks just like our chief financial officer, becomes the acting administrator of Hampton Heritage Hospital in later sessions, blending healthcare administration with business strategies. These shows highlight different aspects of healthcare administration, from hospital operations to leadership dynamics, but they often represent real-life challenges, and they create a skewed perception of healthcare administration for viewers. They oversimplify roles. They violate ethical violations all the time. They neglect administrative complexities, and some of the decision-making, you have to admit, is pretty unreal. Let's move on. Healthcare administrators face heightened challenges in safety net hospitals, institutions that serve vulnerable populations regardless of their ability to pay. These hospitals operate with limited resources while addressing the needs of uninsured or underinsured patients. Safety net hospitals provide inpatient primary and specialty care for Medicaid, low-income, and uninsured populations, and they're required by their organizational mission or a legal mandate to provide care irrespective of a patient's ability to pay. They provide other specialized services, and they often serve as sites for training physicians and other health professions, and they incur a much higher uncompensated cost as a relative to the total share. They do serve as economic engines for the community. Several years ago, they contributed more than $160 billion to state economies and to over 1 million jobs annually. Tell that to the Community Advisory Board. To expand on this a bit further, ethical dilemmas may include resource allocation, financial sustainability, and health equity. Another challenge relates to the transition from traditional fee-for-service payment to value-based that rewards, instead of rewarding volume, to a payment system that rewards providers for achieving better outcomes while containing costs. While fee-for-service has historically incentivized providers to deliver more services and procedures, value-based payments are based on processes that have been shown to improve outcomes. And shown above are some examples of common quality domains and metrics used in value-based purchasing. They include reducing unnecessary or avoidable services such as emergency department care. They measure such things as number of days until patients are seen. And a large role of this, in fact, each and every one of these items relate to patient satisfaction. So therefore, the rules of engagement have evolved, creating additional dilemmas. For example, are we incentivized to provide more or less services? And if so, which ones? We want hospital beds full, but then again, we want to prevent admissions. But the role of patient satisfaction as a quality measure has had a huge impact. Shown above is a dashboard providing a view of key performance indicators that is shown directly tied to patient experience or satisfaction. The dashboard tracks essential metrics in real time, including satisfaction scores, laboratory test completion times, average waiting times, etc. Lower patient satisfaction scores translate to lower reimbursements, creating a downward financial spiral and a divide. Whereas safety net hospitals are disadvantaged in this regard, fewer resources are therefore available to compete with the better resourced institutions. Shown above are the various components as they relate to now. There are payers, providers, there's suppliers, there's government, and all of this with the patient on the outside at some distance from all of these components. And some imagine a future healthcare system several years away of having the patient at the center of all of these components. And of course, how can we have a talk without even mentioning AI as allowing entities to integrate and converge and integrating the consumer health into healthcare? Well, what's more, patient confidentiality is a huge burden. Two recent cyber attacks, those of Change Healthcare and Ascension have resulted in more than 30 million Americans being affected by the largest healthcare cyber attacks, with data breaches affecting maybe even triple that number. And this was during the first half of the year in 2024 alone. And it comes with a big caveat. We're still unsure of how many people have been impacted by these high-profile attacks, ransomware attacks, etc. Moreover, the fatal shooting of United Healthcare's CEO highlights public frustration with our healthcare system, dealing with high costs, and many Americans have expressed outrage with health insurers' practices, which believe priorities have been put in terms of financial incentives rather than patient outcomes. So in summary, health itself is not simply a function of healthcare, but rather a complex interplay of a variety of things, many of which are administered by healthcare administrators, The structure and function of the U.S. healthcare system is tremendously complicated, with a myriad of stakeholders advocating policies in terms of self-interest. All of the components must acknowledge our society's need for healthcare administrators to be leaders and agents for change in this complicated system. The end? No, this is just the beginning. So with that said, I look forward to the rest of our symposium.
Thank you, Dr. Lazar. Thank you for setting the conceptual stage, for giving us some vocabulary, whetting our appetites. Thanks, and for doing so on short notice. Appreciated.